Hi. In this lecture, we're going to provide you with some examples of mediators, moderators, and matching effects that were studied in two major trials of the technology model of alcohol treatment. The two trials were Project Match, which you've heard about in previous lectures in this course, and the Department of Veterans Affairs effectiveness study. In Project Match, if you remember, there was an outpatient arm and an aftercare arm. In both arms of the study, patients were randomly assigned to three different types of outpatient or ambulatory treatment: motivational enhancement therapy, cognitive behavioral therapy, and 12-step facilitation. In the outpatient arm, they were recruited from outpatient clinics that were delivering substance abuse treatment in 10 sites around the United States. In the aftercare arm, the patients were recruited from inpatient facilities as they were being detoxed, or after they were detoxed and finished usually a 20 or 30-day residential program. Three types of mediators were studied. Treatment modalities, we just talked about those three modalities. Therapist effects, and other treatment variables such as attendance at the therapy sessions and AA attendance were also taken into account as mediating variables. If you want more details on Project Match, the book, as well as numerous publications, describe in detail what was done during the trial, in particular, the analyses that were performed on mediational effects within the technology model. And some of those chapters have already been assigned. The three therapies were selected because they were very different and could be well specified according to treatment manuals. And those treatment manuals are available for free from NIAAA. The first therapy that was studied was cognitive behavioral therapy, which consisted of 12 sessions of a meeting with a therapist delivering a set of manual guided lessons almost, and conversations and encouragement and reinforcement that was based on principles of skills training. And the skills training taught patients how to assess high-risk situations in order to identify them and avoid them, how to identify cravings and urges in order to respond to them, not with drinking, but by taking action to change the place that was exposing them to stimuli that were causing the urges. And finally, other skills that have been proven to be useful in avoiding relapse situations. So that's what was done in those 12 sessions of cognitive behavioral therapy. For motivational enhancement therapy, again, guided by a very detailed therapist manual, patients over a 12-week period only had to come to 4 sessions. And those sessions were designed to work with the patient to motivate them to change their behavior. The assumption here is that most patients have it within their behavioral repertoire to change their drinking behavior, at least in the short term. And if the therapist promoted individual responsibility and mobilized those personal resources, provided support and reinforcement to the patient, motivation would carry them through, and that would be sufficient to lead to long-term recovery. And finally, the third type of manual guided therapy that was used in Project Match was 12-step facilitation. Again, 12 sessions designed to promote active participation in Alcoholics Anonymous. The manual mainly worked on the first 3 steps, such as identifying a sponsor and making a commitment to remain abstinent. So once patients identified a sponsor, got set up with a group, and joined AA and began to participate, the therapy was over. But the idea was, by introducing patients to AA, by facilitating their affiliation with AA, that they would get a jump start in recovery. Here's what was found in terms of the effectiveness of the 3 treatments. Patients in the outpatient arm of the study, but this is very similar to the aftercare arm as well, were drinking in the 3 months prior to treatment an average of 70 or more % of the days that they were going to work or trying to function in those months prior to going into treatment. And even prior to that, they were probably drinking just about every day. So once they entered treatment, there was a dramatic change in their drinking behavior, as often occurs with many patients. And the % days abstinent went from less than 30% days abstinent up to greater or almost 90% days abstinent, and that continued for 12 months following the end of the Project Match outpatient treatment. What this graph also shows is that the 3 treatments had similar effects, with 12-step facilitation producing perhaps a slight but not statistically significant benefit over the other 2 types of therapy. In general, the 3 treatments had very similar effects on abstinence rates. Another type of variable that was studied in Project Match is the effects of the therapists. In the groups, the programs that were studied, there were over 80 therapists who were trained to use these 3 types of therapist manuals. And those therapists were evaluated according to their personality characteristics and their adherence to the manuals, and even their recovery status, because some of the therapists were recovering persons. Some of them had never been part of AA or had never gone into recovery because they were never alcohol dependent. So therapist effects were studied, and virtually none of their personality characteristics made much of a difference, nor did their recovery status. Patient outcomes did not differ, for example, according to the sex of the therapist, or whether they were an alcoholic or a non-alcoholic. What was found, though, is that of the 80 therapists, about 4 of them had patients with very bad outcomes. And the question was, why were those patients leaving therapy and relapsing? And it appeared that some therapists are just not well suited to be therapists. Almost all of the therapists did well with their clients, but a few of them had much lower recovery rates. And that's something perhaps in the future that could be looked at in terms of quality control. The point here is that in terms of mediating variables, therapist effects didn't play a major role in recovery. And as you've seen, nor did the type of intervention, the type of therapy that the patients received. Another area that was looked at is treatment attendance and whether that was related to treatment outcomes. And here, treatment attendance did play a mediating role. So the more that patients came to their cognitive behavioral therapy sessions, the more that they came to their 12-step facilitation sessions, the more treatment they received and the better their outcomes. So that's a common finding, that it seems like adherence, or at least attendance at therapy sessions, is highly correlated and seems to impact on treatment outcomes, and therefore it plays the role of a mediator. But as you might expect, the strength of that relationship declines over time. Once patients leave treatment, the effect of the amount or the dose of treatment that they receive declines over time. What about Alcoholics Anonymous? I mentioned that there was evidence that outcomes were a little bit better in 12-step facilitation. And what was found is that TSF increased both attendance and involvement in AA after treatment. So 12-step facilitation did what it was expected to do. It was designed to connect people, to plug them in to an AA group, and to become a part of Alcoholics Anonymous, working the steps. And patients in TSF did a lot better than patients in the other two types of treatment in terms of getting connected with AA. Patients in all three therapies in Project Match were encouraged to go to AA, but it was mainly the patients in TSF that actually connected. What was also found that there were modest benefits associated with AA attendance across all modalities, whether they were encouraged to go through TSF facilitation or not. So if you're in motivational enhancement therapy and you also go to AA groups, you're going to do better than patients who don't go to AA groups. What was also found is that 3 years after the end of Project Match treatment, clients with high social support for drinking, high social support, for not drinking, did better in TSF because of their AA involvement. So when patients were interviewed 3 years afterwards, they reported that they either were associating with people who were abstinent or non-abstinent. And patients who were associating with people who were abstinent were most likely taking advantage of the network of support that AA provides. And the more that their social network consisted of non-drinkers, the better they did. And that was strong evidence that AA is successful because it alters the social environment that provides support to people in the post-treatment involvement. Another thing that was found in Project Match is that if people didn't get plugged into AA during this critical period when they were either receiving 12-step facilitation through a treatment episode in Project Match, or they were exposed to one of the other treatments and encouraged to get plugged into AA. If they didn't take advantage of joining AA during that critical period, that they did not subsequently get involved in AA. So it's very important when people decide to stop drinking, even for a short period of time, for them to use the tools available to them, and AA is a major tool that can support recovery. Another issue in Project Match is that whether people were spiritual or seeking meaning in life, which is often thought to account for some of the effects of AA, that wasn't associated with long-term outcomes. So here's just a graph that shows the sharp increase in AA attendance during that critical period when people were engaged in Project Match treatment. The sharp increase in attendance at AA group in the people who were taking part in 12-step facilitation therapy. There were moderator effects in Project Match as well, but they were not dramatic. So, nor were they consistent across the outpatient arm and the aftercare arm. But patients who were low in psychopathology, high in alcohol dependence, and whose social networks, as I mentioned, supported abstinence, did better in 12-step facilitation. Patients high in anger did better in MET, which makes sense because MET is a laid-back type of therapy where you roll with resistance and don't get into arguments with people. So people with anger seem to like MET. And patients low in alcohol dependence did better in CBT, cognitive behavioral therapy, perhaps because it didn't have as strong of an abstinence orientation as TSF. So in conclusion, why did the matching effects and the moderator variables only have minimal evidence of effectiveness? Well, it could be what is called theory misspecification, that the active ingredients of treatment may be less specific than expected, and maybe the technology model doesn't apply well to psychotherapy process with people who have substance use disorders. It could be research design features. As you saw from all the assessments that we described for Project Match, hours and hours of interviews and questionnaires, lab tests and observations, follow-up interviews, all of that could have dampened the effect of the treatment by overriding it. And finally, what could be happening is matching works outside of therapy, so that the effects of treatment, once people get into it, get transferred to ultimate outcomes, just as a function of people deciding that they need to go into treatment. And therapy itself may have small effects, but not dramatic. But that doesn't mean that therapy isn't important, as we will see from other research. A quick few words about the Department of Veterans Affairs study. This included over 1,800 research participants, and they were recruited from 10 programs in California. And those 10 programs were picked because they represented either 12-step programs or cognitive behavioral treatment programs. They weren't manual guided like Project Match. They weren't set up by researchers. These were real programs in the real world. But that means that the VA study had much stronger external validity than Project Match. The hypotheses were similar to Match. 12-step outcomes would be better for patients with low cognitive functioning, with patients who didn't want to moderate their drinking but wanted to be abstinent, and patients who would have intrinsic religiosity and high alcohol dependence. And it was predicted that cognitive behavioral therapy would be better for patients with fewer coping skills and more psychological symptoms. The findings were very similar to what was found with Project Match. None of the hypothesized patient-treatment interactions were significant, even when they went to the programs with the highest degree of adherence to the 12-step philosophy and the programs with the highest degree or the purest cognitive behavioral training programs. So the Veterans Affairs studies found that patients who were high in alcohol dependence performed more 12-step behaviors, so that was effective at discharge, and it found that being treated in a 12-step program was positively related with learning these 12-step programs and beliefs and activities, but neither dependence nor 12-step program activities were correlated with the drinking outcomes. So like Project Match, the therapies produced the predicted changes in the short-term targets of treatment, either increasing skills training or increasing motivation or increasing adherence to AA principles. But those particular changes, if they occurred or if they didn't occur, were not related to long-term outcomes. So the specific mechanisms responsible for lasting change in the 12-step and the CBT models have not yet been identified. And we can say the same for motivational enhancement therapy. We're still looking for those mechanisms of change. Alternatively, what these studies also suggest is that the post-treatment environment, such as social resources and having a strong connection to people who are abstinent, a place to go if you're tempted with relapse, all of these things may be more important than what goes on during the therapy process itself.